Muy buenos días a todos y a todas. Les damos la
Good morning,
bienvenida
everyone.
a este webinar Cerrando
We
Brechas,
welcome you to
Historias
this
sobre América Latina y el
webinar,
Caribe.
Closing the Gap in Digital Health, Histories of Latin America and the
Este webinar fue
Caribbean,
organizado por
showing
la
you the way
Organización
forward.
Panamericana
This
de
has
la
been
Salud,
organized with the Pan American Health Organization, which is our strategic ally on digital health
Les doy el
matters.
pase.
First, let me
Luis
introduce
Tejerina es un
myself.
especialista líder
I'm
en
Luis
PAHO
Tejerina. I'm
y
a
desarrollo.
leader at
Hoy les estaré
PAHO on the
acompañando
subject matter.
a todos
Today, I
ustedes.
will be moderating this
Muchas gracias a
webinar.
todos y a
Thank you
todas por
very
estar
much
aquí.
for joining.
Antes de comenzar, unos
Before
comentarios.
starting, just some
Tenemos
technical notes.
interpretación
We
en
do
inglés,
have
alemán, portugués y
interpretation
portugués.
available into
Ustedes pueden seleccionar
Spanish,
su
Portuguese, and English.
idioma con
You
este
can
botón
choose
que
your
dice abajo a la
language
derecha de su
using
pantalla. Y también
the
vamos a tener
Earth
llamadas
icon at the
telefónicas y
lower
nos
part
pueden
of your
escribir o
screen.
puedan enviarnos preguntas
And you
por
can also
escrito.
send your questions in on the chat function.
Para entender un poco la dinámica, les cuento cómo vamos a organizarnos.
Now, let me tell you
Antes de
how
comenzar,
this is
nos
going to
va a
work.
dar la
Before
palabra
starting, we're going to hear some
representantes de
words from
IDBS.
representatives of the
Después vamos a
IDB and
escuchar
PAHO, and then
historias
we are going to
de
hear
viajes de
some
las ciudades de México
stories, one
y
from
Suriname,
Mexico City,
y
one
otra de
from
las
Suriname,
Bahamas.
and the other from the
Serán
Bahamas.
presentaciones breves para
These are
permitir
going to
un
be
poco
brief
el
presentations
espacio de
to
preguntas y
allow
respuestas
for
y así poder aprender un poco más
questions
de
and
experiencias
answers,
de ambos
and so that
países.
you can learn more about the
Entonces,
experiences that these countries have had with telehealth.
para comenzar,
Without further
voy
ado,
a comenzar dando la palabra
I'm going
a
to give the
nuestro jefe
floor
de la División de Salud, Javier Guzmán,
to Javier
que
Guzman
nos va a dar
from the
unas
IDB,
palabras para
who has some
comenzar esta
opening
charla.
remarks to make.
Javier, adelante.
Muchas gracias, Luis. Bienvenidos y bienvenidas. Es un placer para mí estar acá con ustedes.
Thank you,
Como lo dijo
Luis.
Luis,
As Luis
hace
said,
2 semanas inicié en el banco como el nuevo jefe de la división de salud
too
de
much
operaciones de
background
negocio.
noise, says the
Y una de
interpreter,
las
making
cosas
interpretation
que me
very
gustaba del
difficult.
banco era que en la región habíamos progresado mucho de salud digital. Y es para mí un placer ver realmente. Hay mucho ruido, me dice. ¿Me oye bien?
Creo que ahora sí.
Maybe now.
Creo que el problema es que sí es un sitio ruidoso. Bueno, yo solamente quiero saludarlos. Tenemos
I really just wanted to
países en la
greet
región,
you. We have 20 countries in the region.
bueno, de pronto, Marcelo, si quieres empezar y yo me muevo
Perhaps,
para allá.
Marcelo, you could start, and I'll
Gracias,
try
Marcelo.
to. Well,
Vamos adelante con
go ahead,
Marcelo.
Marcelo.
Marcelo ya va a
We give
estar
the floor to
que nos va a dar el pase esta
Marcelo
vez.
from
Adelante, Marcelo.
Pajo.
Sí, muchas gracias Luis, muchas
Thank you
gracias
very much, Luis. Thank you, Javier,
por organizar este evento. Es un
for
honor
organizing this event. It's a
participar
pleasure for us to
en este trabajo conjunto que
forge
tenemos
ahead in this
entre la
joint effort
IDB y la
between the
Organización
IDB and the
Panamericana
Pan
de la
American
Salud
Health Organization
sobre la salud digital,
in
transformación
the area of
digital y sistemas de
digital
salud.
transformation, telehealth,
Hoy
digital health.
nos queríamos
And
concentrar
today we want to
más que en el qué,
focus
en el cómo y en el
more
impacto que
than
tienen
on what, on
proyectos sobre
how,
salud
and the
en la
impact
región.
that
Queríamos
projects
poder
are having. Our idea
anunciar
is
y
for us
compartir
to
experiencias
announce that we
de
will be
México, de
sharing some
Surinam, de
experiences
Bahamas,
from Mexico,
países que
Suriname, and the
trabajamos muy
Bahamas,
de cerca,
countries with whom
países que han
we
trabajado
work
desde
quite
el
closely,
inicio
countries that have been
de esta
working on
iniciativa que
this
venimos
initiative from the outset.
trabajando juntos prácticamente desde
We've
el
been
año
working together since
2016, si mal no recuerdo,
2016, if I'm not
y hoy
mistaken.
se ha
And
oficializado inclusive con un
today,
acuerdo
it's
firmado
official
entre el
with an
mismo
agreement
IDB
signed between
en el
IDB
marco
and
de un
PAHO
proyecto
within the
mayor
context
en
of an
conjunto que es
overarching project
la
that we have
implementación
together,
de la
which is the
autopista
implementation
panamericana
of the Pan
de salud
American
digital. Entonces, para
Digital
nosotros siempre es un
Health
gusto poder
Highway.
compartir esta
So it's a
actividad
pleasure
y
not only
todo
to
lo que
share this
se
activity
realiza
with
con
you,
ustedes y con el BID.
but everything that
Y en este
PAHO
sentido
and
también
IDB
quería expresar en nombre de
are
ustedes
doing
muchos
together.
éxitos a
So
Javier Guzmán
best
en,
of success to
en
Javier
este nuevo
Guzman
rol que viene a
in
tener
this
acompañando
new
toda esta
role
sociedad que
that
tenemos entre la
he
OPS
will
y el
be
BID.
playing in
Y
this
con esto le
association,
devuelvo la palabra a
partnership
Javier.
between
Queríamos entonces
IDB and PAHO. And so we give
desearle
Javier
muchísimos
back the
progresos
floor.
y éxitos,
Thank
Javier.
you, Luis, and best of success, Javier.
Muchas gracias, Marcelo. Espero que ahora sí me escuchen mejor.
I hope you can hear me better now. Is that better? Great.
Yo estaba diciendo que llevo
As I was
2 semanas
saying,
en el BID como jefe de la división de
I've
salud.
been the head of health and population at the IDP for just a couple of weeks now. And one of the things I used to hear before coming here is that much progress had been made in digital health in the region. And there are two key things in this progress. First, the collaboration with PAHO, which is a partnership that we have had going for a couple of years. This is a common front that we have put together, and we do have a strategic long-term outlook, and this is very important because we can see how countries are asking us about System A, System B, or electronic clinical files. 15 countries have actually created a digital transformation roadmap, and that's very powerful because that helps them to have a long-term view. Now, one of the key aspects, Marcelo, this is just the beginning, and the idea that we have now is for there to be a Pan-American roadmap, means with which we can exchange information among the countries, and I'm very excited about this. And I think it's excellent that we have financing from the government of Japan. 14 countries have said that they will indeed take part. We hope that many more will join and that we have some tangible success stories to tell you about, some of which we'll be telling you about today on this webinar. We want to show you how you can achieve this success. You can move forward in this undertaking, and hopefully this conversation will be very fruitful. Luis, thank you very much, both of you. I think it's wonderful that we can see this joint effort. Now, to get started, I want to introduce Jacqueline Velasco Romero from the Public Health Department of Mexico City, and she is going to tell us about a pilot project that was carried out on telehealth developed in Mexico City. Jacqueline, let's have you share your screen and hear what your experience has been. You have the floor. Jacqueline, I believe your microphone is still muted.
Gracias. Buen día
Thank
para
you.
todos.
Good morning, everyone.
Como ya se ha mencionado, mi nombre es Jacqueline Velasco.
My name is Jacqueline Velasco Romero. I am a first contact doctor from the health unit of Xochimilco and well-being in the city of Mexico City. I thank the organizers for inviting me to this webinar. I'd like to start with an overview of diabetes in Mexico, an epidemiological overview. We have 9 million inhabitants in 2023, with a prevalence of 2.6% of diabetes mellitus. This is the second cause of death. Therefore, we have public health services that on which there is a great demand by people who suffer from this disease, so that we can offer timely assistance to these people. Last year, we implemented the pilot telehealth program, a project that we started in 2023 and that went into full force in May and June of 2024 with the participation of Dr. Oscar Suarez, who is a doctor from the and from myself from the health unit. Telemedicine, doctor's visits don't require a patient to actually go to a second level of care. This is carried out by a diagnosis is carried out, blood tests, urine tests, electrocardiograms, and also x-rays of chest x-rays. Through our platform, we can carry out a triage and we can make appointments for the patients to see the doctor. So televisits serve to collect the necessary information by the specialist, physical exams, and making it possible to come up with the diagnosis and treatment plans. Televisits allow for a dynamic interaction between the first contact to doctor, the specialist, and the patient in a safe environment where people feel they can trust their providers. Now, this had a multiplying effect, getting people to actually stick to their medicine regimens, and this also helps people keep their disease under control, reducing short and long-term deleterious effects. So this was a real watershed in medicine in our country. This enabled me to adopt an overall comprehensive, thorough understanding of the patient, which also enables us to diagnose better and to add new knowledge to what we know about the patient regarding the medicines they will be taking, and we can, in a short period of time, control these patients better. I would also like to tell you that most of the patients who take part in this telehealth project have been able to stick to their targets, their goals, and treating their disease without having to actually go to a physical or brick-and-mortar health unit. So when each patient that is treated this way, they usually stick to their treatment goals, and it has a palpable positive effect in the country, avoiding acute chronic problems or need for dialysis or other high-cost health care services. I would like to thank the Inter-American Development Bank and the Pan American Health Organization for this opportunity to share with you this very enriching experience, which today I proudly represent my country in speaking to you, Mexico. Thank you very much.
Muchísimas gracias, Jacqueline.
Thank you, Jacqueline.
No se olviden que preguntas acerca de la intervención pueden dejarlas en
Don't forget that you can type your questions into the chat or the Q&A function on Zoom. Now we're going to hear another experience from Suriname. We're going to give the floor now to Richard Mendez, who heads up the 4H unit, which is an initiative that was led by PAHO, enabling many countries to roll out digital health strategies. And Richard is going to tell us a little bit about what Suriname's case was in implementing this 4H system. You have the floor.
Good morning, afternoon, everybody. My name is Richard Mendes, and I'll be representing the Ministry of Health of Suriname, mainly on the topic of the digital mortality registration system. So it's one component of the IS4H platform, of course. I'll just jump right in. Mortality data is very important for Ministry of Health. It's basically a compass that guides health priorities, but also exposes certain burdens of disease and measure specific impacts of interventions. So without accurate mortality data, health policies can become reactive instead of strategic. And looking at this part, we had a serious issue in Suriname, where for the last 10 years, we had no official mortality statistics published. So it wasn't the case that we didn't collect the mortality data, but the issue was that the quality of the data was very low, but also the way it was recorded. So the interpretation of the data was very hard because there was no standardized classification, and the reporting practices were very, very difficult. So we discussed this within the Ministry of Health and decided to standardize this approach. And on the slide, you see on the left side the manner that we registered the mortality previous. So you see that it was with a paper-based form derived from 1956, so it didn't change until now. And by doing it on a paper-based form, most of the physicians would just say the cause of death, and that was it. So no underlying causes, not according to WHO standards. And what we've now done was made a digital system that guides the physician through the approach for registering a mortality case and according to the WHO guidelines. So specific parts that are in there are, for instance, the register of demographics, the chain of events leading up to the mortality, but also the significant conditions, other medical data. And one of the most important parts is that we included the ICD-11 registration, mortality coding registration in it. So the chain of the chain of cause of death is basically registered according to the ICD-11 standards. And if we look at the mortality registration in the previous case, there were two forms that were used by a physician. It was the A form that was basically containing demographics of a patient, and then it was the C form that was containing the health information. Those were both given to the family of the deceased person and sent, or they had to bring it to the civil registry. And then the civil registry would provide a certificate of mortality, and then the family could use that certificate for arranging burials for the deceased person. On the other hand, the C form would also go to the civil registry on a closed envelope, and they would send it off to the public health agency. And then at that point, they would interpret the data, enter the data into a type of analysis tool, clean the data, and analyze the data. So by going from a paper-based system into a digital system, a lot of steps are being bypassed, basically. So the registration of demographics is done within the digital certification tool. And that would automatically be sent to the public health agency, but also sent to the civil registry. I have to make one disclaimer here. The part that it is sent to the civil registry is now still under construction. So, and it has to do with the different ministries, and the Ministry of Internal Affairs didn't want to have this embedded yet. But I will talk about that a little bit later. But the information is now standardized, at least the health information is now standardized and then automatically sent to the public health agency, and they can analyze it. So of course there were some challenges that we came upon when we included this system. There were two main concerns actually. The physicians said it was more time consuming, but than the paper-based system. But if you look at the reason why it was more time consuming, it was that the paper-based form wasn't correctly filled in. So we had to train all the physicians in filling out the mortality in a correct manner. So that took more time than just registering the cause of death. So that was one of the concerns. And of course, the second one is the digital aspect. The change toward the digital system, although we made it very intuitive, is just a change for physicians that is sometimes troublesome. So we are training them constantly to getting that done. And what we see now, we've been launching it from the 1st of January. And what we see is that for primary physicians, the system works appropriately, but for physicians in the hospital, there are still some issues. And for the future, what we now done is that we're building that as we speak, actually, is that an administrative department can fill out all the information and then allocate the certificate to a physician that can evaluate whatever the administrative department filled in, and then register the cause of death himself. And then it will be sent back to the administrative department that will basically follow up and send the original version in the tool to the public health agency. On the other hand, what we are also trying to do is connect the tool with DORS, so that there's feedback to the physicians if the chain of cause of death is also registered correctly. So that's where we stand at the moment.
Muchísimas gracias, Richard. Muy interesante. De hecho, tengo algunas preguntas, pero las vamos a dejar para el final.
Thank you very much. That was very interesting. I do have some questions, but we'll leave that toward the end now. Dr. Philip Swan, the acting director of the Department of Health of the Bahamas, who's going to talk to us about progress made using the same model Suriname is using now in the Bahamas and the impact that this has had on people's daily lives. Dr. Swan, please, you have the floor.
Hi, good afternoon. Can you hear me?
Yeah, we can hear you.
Excellent. So basically, I'm here to talk about, as you said, Serious. We talk about what the Bahamas is doing in the area of IS4H. If you look at the second slide, it talks about the picture of the Exoma Keys and Land Park. Just Bahamas is a country with 298,165 persons, according to our last census, finally released this year. And we have a health system that sees about 400,000 persons, 400,000 visits each year in the primary care sector, and a national health insurance that is registered for 160,000 of our persons. The questions for us that came to IS4H, as was mentioned earlier, is what is it? So it is a national initiative led by the Ministry of Health. And Department of Public Health is one of the arms that is moving it. And it's to modernize and strengthen the health system through information systems for health, as a powerful initiative that we undertook with assistance from consultants from the IDB as well as PAHO directly about almost 5 years ago now. I'm at the stage where we're in the process of implementing this action plan. The idea is that it will focus on enhancing our service delivery to digital platforms like the Bahamas EMR Plus, which is our adoption of Open EMR, the Bahamas National Patient Portal, which is a health information exchange, and of course the SIP Plus platform and EIRS, PAHO native platforms. It's also aimed at strengthening data governance, interoperability, and accessibility, as well as building capacity among healthcare professionals and supporting better patient care and health outcomes by transitioning us from paper-based to digital systems that help with that health surveillance and health intelligence that's important. The IDB, of course, is a strategic partner, providing us with financial and technical support to the IDB loan programs that we have access to. It's important to us because we understand at the end of the day, it will help us to enhance our healthcare delivery. It'll help us turn towards a more patient-centered care structure and also help strengthen our data systems. One of the challenges that we're working through is the interoperability between existing or legacy systems like our lab information systems, our imaging systems, with the new electronic health records. We're working through it step by step and having some success. Of course, this whole process will help us to support our national health priorities by providing us with key health data management processes, and effective dissemination of information. Capacity building is one of the other things that helps us to do through training of our staff and the use of health information systems to support delivery of health services. I would focus on the Bahamas EMR Plus, which, as mentioned, was an enhanced national electronic medical records platform. It basically captures digitally managed patients' health information, supports the continuity of care, and we have seen it's now improving efficiency and accuracy and timeliness of healthcare delivery and data reporting, allowing us to make data-driven decision reports. One of the things we're trying to get out of it at this point in time is that weekly syndromic process. We want that to give us an automatic report, and we're far along that process of trying to ensure that. The other component, of course, is keeping track of what is the cost of delivery of health services. Not that we're charging these costs, but when it comes to having discussions with our funders, Ministry of Finance, and external agencies, it gives us an idea as to what is the cost of delivery of healthcare services and how we can make tweaks to ensure that the system stays afloat, so to speak. A second thing I want to talk about is the SIP Plus, which is basically the parental information platform that PAHO provides. We're in the process of training all of our midwives, physicians, and nurses who see pregnant women on the system, and we hope to be rolling out by the end of this month, which is in a few days' time. Will help us to impact the data that we have in the management of pregnant patients. What is expected going forward is basically further strengthening of the health information system, further strengthening of how it is that we are going to ensure that data is collected when the encounter happens with the patient. That allows us to tie in with other systems. One of the things we're looking at the public health surveillance from a public health perspective, help us to track what else happening in the environment and how it impacts what happens with the patient. I think I'd stop there for now. I'm not sure if I took too much time or too little time, but I think I'll stop there. And we are open to any questions you may have. Thank you.
Muchas gracias, doctor Swan.
Thank you, Dr.
Bueno,
Swan.
tenemos tres experiencias
We've heard three different experiences now
de tres países bastante distintos
from three
en términos de
very different
implementación
countries
experiencias de
regarding
telehealth.
how they have gone
Y
about
estoy
implementing
recuperando algunas de las preguntas.
digital
Yo tengo
health.
algunas.
And I see some of the
Invitar a todos
questions that have been put in the Q&A. I would ask
sus preguntas
everyone to
en el
please
chat
write your questions
y
into
voy
the
a ir
chat
canalizándolas un
box, and
poco
I will
agruparlas un poco para que podamos
read a couple of these questions and ask our speakers to answer
El
them.
primer grupo creo que
The
va
first group
en
of questions are for Dr. Jacqueline
la implementación en México.
regarding the implementation of your system in Mexico.
Preguntas, creo que puedo, hay varias que apuntan un poco a tener un poco más detalle de lo
There
que es
are a
lo que
number of
se hace.
questions that are requesting more information
Primera,
in detail about what you have done. How many patients took part in this study?
¿Cuál es el
Is the first
porcentaje,
question.
si es que lo sabemos, en
And
comparación
do we
a
actually
la
know what the
tradicional?
difference is between the new digital system and the traditional system as far as adherence by patients to their treatment? Which specialists are actually taking part in this? Do you use the electronic
Yo las conozco más, he estado
clinical
más en zonas
file?
rurales o urbanas.
What was the criteria that you
Caso, una
used,
pregunta que
selection
creo que
criteria
va a tener
for those
es
patients who are
¿cuál es
to
el
be
proceso
included under
llegar a
this
áreas
telehealth or teledoctor's visit
tecnología digital?
system?
Yo lo veo
What
igual,
are the main areas where it's
una
being
pregunta
used in the urban
es
or
por las
rural
que
settings? What were the major stumbling blocks or hurdles you had to overcome?
Dice, ¿cuántos pacientes participan en el
Now, how
estudio?
many patients
Esto me muestra
took part in this study?
33 pacientes.
33 patients to start with
Criterios de
was our
inclusión
sampling. The inclusion
fueron
criteria
pacientes de no
was
más de
that
6 meses de diagnóstico de diabetes mellitus.
they
Sin
be patients
embargo,
whose
para
diagnosis
poder
of
recabar la
diabetes
muestra,
mellitus not be more
tuvimos que
than 6
ingresar
months
a pacientes que ya
old.
tenían más tiempo de evolución. Pero esto fue bueno al final porque
We
fueron los
didn't
pacientes
want
que más se beneficiaron y los que más se apegaron a tratamiento.
diabetes patients who had had diabetes for
Pues la
very
siguiente
long
pregunta.
because we wanted to make sure
En
that
la
the
prueba
ones who took part in this
complementaria,
program were within a window within
sí
which they could
noto
actually
en la
be
teleconsulta, se
helped.
puede notar que en la consulta
I do
todavía no
see
hay. ¿Por qué?
that
Porque hay
adherence
mucha
to
presión,
treatment
perdemos en cierto momento la secuencia
is greater with this digital system because sometimes people just don't stick to their treatment when under the prior system. Now, through this platform, the Mido platform, working together with the IDB and the Carlos Slim Foundation, it was much easier, or has become easier for us to have access to the patient's electronic file, to see each step of the way how the ailment has evolved, and this can be done in a very personalized, tailored way for each patient. So that was something that made us very pleased to see how this worked.
Also say that of the patients that we followed up, 70% continue following up their consultations, and they continue punctually to come into the consultations and checkups.
La siguiente pregunta.
Había
So
una
the
en cuanto
next
a
question,
limitaciones.
well, looking at some of the limitations,
Como si me acuerdo bien, los centros eran bastante, no eran zonas rurales, sino que eran zonas
if
urbanas.
I
Entonces,
recall,
normalmente en zonas
these
rurales uno ve
clinics
limitaciones
were
de
in
conectividad, por
urban
ejemplo, porque están
areas.
afuera. En
We
estos
know that in
centros, ¿cuál
rural
diría usted que
areas,
fueron las
there's issues
limitaciones
with connectivity.
particularidades urbanas
What are
de
some of the
dificultades que tenían los
some
centros?
of the challenges that were faced in some of these medical centers? Well, we're in the periphery of the metropolitan area of Mexico City, and connectivity sometimes fails. But here in Xochimilco, we have the advantage that we can carry out these actions without too many issues. The advantage for the patient is that they don't have
Desde
to
aquí se le daba la atención de
uh,
especialidad
be brought into
y se
any
les hacía los
hospital. Here
ajustes
we
correspondientes
have
a su
the
tratamiento.
areas of
Entonces,
specialization and adjustments can
pues
be
ellos lo
made to
único que
their
tenían que hacer era no
treatment. The only
perder
thing
la
they
secuencia, ¿no?
needed
Seguir
to do
acudiendo
was
a sus
just
consultas
make sure
para
that
ver
they
resultados.
followed up
Y
all
eso
of their
también
medical
fue muy
checkups
bueno para ellos porque
and
al ver
show
que
up.
realmente estaban
And
obteniendo un
now that
beneficio,
they saw that they
pues
were
se
getting
adherieron más todavía.
meaningful benefits, then the level of
Y acá,
adherence
yo estuve en la parte de
increased.
selección de los centros y
So,
puedo
looking
comentar que
at the
cuando se hizo
medical
para
centers
hacer la selección se hizo
to
un
conduct the
levantamiento de
selection,
un modelo de madurez que fue
we
levantado durante la
first
época de COVID,
had a
fue
survey,
un
and
ejercicio
this
que
was
fue
during
liderado
the
por la OPS, de
COVID
hecho, pero
vaccine,
entonces se hizo un
during
levantamiento
the
de
COVID
los centros de salud de
pandemic.
la Ciudad de México
And again, there
para
was a
ver, ¿no?
survey of the
Cuáles podían ser los
Mexico
mejores que se
City
prestaban más para un
clinics
ejercicio de este tipo.
that were
Que
more
creo que es
conducive and
un
apt for
ejercicio
this
recomendable
type of
para, en
exercise. And
general,
I
¿no? Ver
recommend that practice,
el
that
diagnóstico de cuál
we
es el nivel de
first
madurez
need to come up or
de todo el
develop a
universo de centros para
diagnostic of
ver
the
cuáles se prestan más
level
para
of
hacer una
development
intervención de ese
of
tipo.
these medical centers and clinics to see which are the ones that are
Creo
most
que de las preguntas, por lo menos de la
appropriate
primera
for this type
grupo
of
de preguntas que tenía,
process
las
and
respondió todas.
exercise. Well, you've responded to
Tengo
all
un
the
par para
questions
Richard.
posted. I have
Eh,
one for
una
Richard.
es, Richard,
One,
¿cuánto tiempo
Richard,
tomó la
how much
implementación de
time
los
did it
cambios?
take to implement the
Y
changes?
una
And
segunda que es mía,
a
que
second
es,
question,
me
that's my
pareció muy
question. I
interesante
was very interested
que
in seeing
la
that
versión a
the
migrar a la parte digital
the
en
migration to
parte era
the digital
porque la
component was
parte
partly attributed
papel
to the
no
fact that
estaba siendo llenada correctamente.
maybe the
Entonces,
records weren't
cómo
being
fue la
filled in
reacción
properly.
del
So, what
personal de
was
salud que
the
tenía que
response to the
comenzar a
health
llenar esto?
personnel that had to start
Y
filling
en
in
cierta
these?
manera
And to a
se
certain extent,
visibilizaba que
uh,
no se estaba haciendo
we
un llenado adecuado.
perhaps it was how did you how were you able to detect that the forms were not being filled in properly?
Okay, answering the first question is we started the pilot in August last year for 3 months and just approached mainly the primary physicians. And I think we had 60 primary physicians that were just piloting the system. That took 3 months. And after that, there were, of course, some technical issues that we solved. But after that, we started the 1st of January officially with the official launch. So from the 1st of January, we even passed a law that everybody had to use the digital system to register the death certificate. So that's the first part. The second question concerning how we to notify that the forms were incorrectly registered is the trainings. So we've done trainings to all physicians. So they're only allowed to be registered in the system if they underwent the training. And during those training sessions, we found out that the physicians by themselves said, okay, this is something completely new. And after I think the second or the third training, we moved the training slightly more towards how to fill out a digital death or death certificate correctly. And that was received very well. The issue that we had with the training is that the staff in the hospitals is very reluctant to go undergo training. It's always a time-consuming part, and they say they're very busy, etc., etc. But it's in their job statement that they have to register mortality, and by forcing them to do it digitally, and they can only access the system when they underwent the training, they are forced to undergo this training. So this is basically the approach we're doing, and there are still ongoing trainings every 2 weeks. And we have a trainer system, so every hospital has their own trainer. And for the primary physicians, we have a group of trainers that are performing this, also consisting out of physicians themselves, of course. I hope this answers the question.
Sí, una pregunta para Bahamas,
I
y
have a
no
question
sé
for
si
the
el doctor Juan va a
Bahamas.
estar me parece que tuvo que salir, la
I
respuesta nos
know
los va
that
a dar Michael
our
Hamilton.
speaker had to
Pero la
leave,
pregunta
but
para Bahamas es,
this is the question for the Bahamas. When the pilot project was launched in the Bahamas, how has the process developed and unfolded? What has been the response to the public health personnel and staff to the changes? And what are some of the challenges that you encountered in transitioning to the digital component?
Esperamos a que llegue la traducción.
Can you hear me?
Yes, Michael.
Okay, brilliant. So apologies, everyone. Dr. Swan had to step away, multiple commitments. So the substitute responded, and I hope I can do a good enough job. So our experience was similar to the Surinamese experience. I mean, people are people wherever they are in the world. And one thing is for certain, humans tend to resist change even when they want it. So they'll resist it passively, and some will resist it in other ways. What we found, however, even before we got to the resistance, was that we had to prepare the personnel in the clinics for a digital operation. So what do I mean by that? When we did a survey, we recognized that a significant number of the personnel were not digitally literate. So we had to address that. So we developed Introduction to Computers levels 1, 2, and 3 courses, and persons had to either take the courses and pass them or pass the exam if they felt that the course was not something that they needed to do. So once they passed the exams, they didn't need to sit the courses. But if not, then they had to sit them. And then what we did, we selected two of the smaller clinics because the best way to eat an elephant is one bite at a time. So we didn't try to cook the entire elephant. We took two of the smaller clinics and we started our pilot project with them in February. February 3rd and 4th, we launched at Adelaide and Gambia clinics. So taking that approach and training the nurses separately from the doctors, we have been advised that there's some kind of, I don't know, it's a professional feeling that the doctors believe that they need special attention and care. And we were cognizant of that and we acted accordingly. Also, we had multiple sessions with the clinic personnel to ensure that they were comfortable. We showed them what to do. We had practice runs. And while they were live, we were physically in the clinic, at least three of our personnel with them, for an entire month. So we were on the ground in the clinics with them, helping them to actually utilize the system and to document their concerns and try to address them as quickly as we can. So that was an important thing. They needed to understand that they were being heard and that not only were they being heard and that we said, oh yeah, we heard you and we moved along, but that we were actually doing something about their concerns. So that helped a lot. And then in quick succession, we started with PAHO on the SIP Plus records, and that training is going on right now. So we're doing multiple systems in parallel. I hope this answers.
Sí, muchísimas gracias. Y creo que es muy útil para muchos otros países que están
Yes, thank
implementando
you. And I
sistemas
think that's
similares.
highly useful for other countries that are experiencing
Para
similar
iniciar
transition
sitio,
processes. Now I'm going
con una
to
pregunta para la doctora Jacqueline.
move on to another question for Dr.
Doctora,
Jacqueline.
queríamos,
Doctor,
alguien nos pregunta, y de hecho
somebody
también me interesa
asked us
mucho
in the
saber
chat,
cómo se está
they want to
pensando
know
hacia el
exactly
futuro la implementación
how do
del
you
piloto. ¿Cuáles son,
envision in the
cómo
future
esperamos
the follow-up
que sean las
implementation of this
siguientes fases?
pilot project? What are the
¿Qué tipo
next
de
steps
participación esperamos
forward? What
la
kind of
parte del
participation
gobierno?
do you
Cómo estamos viendo el
expect
futuro
from the
de la implementación
government?
del piloto?
What are the next steps
Muy
as
bien.
you view the
Bueno, hemos tenido
future?
algunos cambios administrativos.
Well, we can
Sin
start
embargo,
off
el
with
proyecto
some
se presentó el año
administrative
pasado
changes. Now, the project
ya
was
con la
launched
nueva
last
administración.
year with the new government
Ellos,
administration,
pues, de momento
and
no nos dieron
currently
algo seguro, pero va a
we
quedar
haven't
en mesa
gotten
de
anything
trabajo junto con ellos
etched in stone yet, but we
por
are
los
continue
beneficios
to
que se
work.
otorga al
We're
paciente.
continuously working with them in terms of responding to our
Al
patients.
parecer, vamos a trabajar con los
And
médicos
we're
especialistas de
going to
otras
be
unidades que ya
working
existen, que
with
es nada más una metapa,
specialists from other
y que bueno,
units,
ellos trabajan con
and
médicos internistas.
they're
Entonces,
working
para que el
again
enlace
with
se pudiera hacer con
internal
ellos y ya
medicine
no con los médicos de
specialists,
los hospitales.
and not just
Pero bueno,
with
eso aún es tentativo,
the
no tenemos
hospital
nada definido todavía.
physicians. But we still, this is still at a tentative stage. We don't have
Sí,
anything
bueno, uno
concrete yet. Well,
de los
one of
elementos que ayudan
the
con
components that
estas
I
etapas de
think that have
transición es la
helped
buena
along the
documentación
transition
de las
is
experiencias.
accurate
Sé que
documentation of
en el caso
experiences
de Ciudad de
gleaned.
México,
In the case of
se hicieron
Mexico
esfuerzos también por
City,
documentar
I know
lo mejor
efforts were
posible
made to
todos los procesos
accurately
y toda la
document
implementación justamente para hacer estas
the processes, the steps
abogacía, ¿no?
forward to sort
Para
of
algo que pueda sobrevivir
advocate
diferentes
for something that
administraciones.
continue
Voy
to
a
be
pasar
something
a una
permanent
pregunta
that
para el señor, para
transcends
Richard.
individual
Richard, nos
administrations.
pregunta alguien el
Richard,
tema de
somebody's asking
interoperabilidad.
us in terms of interoperability.
Tenemos un par de preguntas
We have a
relacionadas
couple
con
of
temas de
questions
interoperabilidad
dealing with
y sistemas
interoperability
heredados.
and legacy
Específicamente en esta
systems.
querían saber
And I'd like to know
cómo
how
funciona el sistema, qué tanta
does the
interoperabilidad
system
tiene para
operate? What
comunicar
level of
en el momento que
interoperability
una persona fallece a
exists
distintos organismos del Estado.
with
¿Qué
various
comunicación
government
existe?
agencies? Let's say, for example, in the case of a patient that has died. Thank you.
Okay, so we are currently in the construction of a health information exchange platform. And the EHRs of the primary physicians. So our focus in Suriname is on primary healthcare. So that's important to know. The secondary healthcare will be in a second phase, but we're not focusing on that yet. So the digital death certificate is connected to the health information exchange platform, or will be connected. And the data is then being shared to Civil Registry automatically through a dashboard. And the data is being shared with BOG. So that's the public health agency, also through the health information exchange platform automatically. And then the patient that is deceased is being the physician, the attending physician is being notified in their EHR system. So that's still in the build process currently. But all the preparations basically and the architecture set for the digital death certificate, the standards, etc., are all aligned for this. Basically.
Y aquí importante también entender que
One
en la
thing it's also
implementación,
important that in the
tanto de Surinam
implementation,
como de Bahamas, de
both in
hecho, se están
Suriname and the
utilizando
Bahamas,
plataformas de intercambio de información,
you're already
Health Information
using
Exchanges, ¿no?
health information exchange platforms.
En la siguiente pregunta tal vez nos puedes contar un poco más de
And
eso,
maybe
pero
in the next question, we'll find a little, we see a little bit more
hacer una
mention about
pregunta
that.
que
But I also
me
wanted to
parece a
ask
los tres casos
something that I think
y creo que es
involves
de
all
mucha
three
relevancia cuando
case
pensamos
studies
en
that
una
are highly
migración a
relevant
sistemas digitales.
when we look at migration
La
of
pregunta es,
digital data systems. The question
¿cuál fue
is,
la planificación
what was the planning
em,
process
eh, de
that
mecanismos de contingencia?
involved
Mecanismos de
contingency
contingencia para cualquier
mechanisms
eventualidad, dado
for
que estos
any
sistemas pasan a ser
unexpected
sistemas de funcionamiento crítico.
activities during
Em,
critical events.
Perdón.
Here we go. What,
¿Cómo se definieron los planes de contingencia habida
how
cuenta
did
de que
you
esas plataformas
determine
pasan a ser
the
de emisión crítica?
contingency plans?
Entonces, entiendo que son cosas nuevas y pueden ser
I understand that
preguntas
these
muy nuevas, pero
things
quería saber si
perhaps
pensaron
are
algo
very,
en esto.
just looking at any special situations that like these for where you would need contingency plans.
La pregunta es para cualquiera
The
de los
question is
tres.
for any one of the three, our three speakers.
No sé si. Doctora Jacqueline,
Dr.
sí.
Sí,
Jacqueline?
sí, bueno, nosotros
Well,
tuvimos el
we
apoyo de la Fundación Carlos Slim en todo
have the
momento.
support from the
Ellos
Carlos
fueron los que
Slim
estuvieron
Foundation.
operando, piloteando
They were
la
involved in
plataforma.
the piloting
Y
and
cuando
the
nosotros teníamos algún
operational
contratiempo,
aspects
pues
of
de
the
inmediato
platform.
nos
If we ever had
enlazábamos con
any
ellos a través de una
emergency
mesa de ayuda, un
situations,
centro
we
de
had
ayuda
this
ubicado en la misma
help
plataforma
desk. The help
para
desk
recibir de
would
manera
provide
inmediata
us
la
through the
respuesta.
platform an immediate
Si tuvimos
response to
algunas
any
fallas de
unforeseen.
conectividad,
We had, for example, some
eh,
connectivity failures,
no sé,
another
también en cuanto a el agendamiento de
unexpected
los pacientes, pero
situations
bueno,
like
se pudo
that.
subsanar a través de
But
esta mesa de ayuda.
this was supported through this help desk from the
Michael, Richard,
foundation.
planes de contingencia,
Michael,
pregunta
Richard,
nos quieren
any
comentar.
contingency plans that you would like to
Sure,
address?
Louis. Well, we had major issues, not small ones. So, for example, when we started rolling out our electronic health records, we were going with a commercial solution, and then we got a ministerial directive to cease and desist. So this is after we had already trained our trainers and started working with some of the clinics. So then we had to press the stop button, huddle, brainstorm, and come out of the gates flying again. So what we did, knowing the procurement process would take some time and time was not on our side, we went open source and we customized Open EMR, which we now have branded BEMR, Bahamas EMR Plus, which is what we have rolled out in the clinics. Also, we had built an appointment scheduler to work with the commercial solution because the commercial solution appointment scheduler was too expensive. But with the Beamer solution, the scheduler is also in the solution, so we're using that. And we're now integrating it with the existing government billing application, and we're expecting to roll that out in a few weeks, all being well in May. So that's just one example of where we had to pivot based on unexpected turn of events.
Richard?
For us, it was actually the same thing as Michael explained. We initially went with a commercial EHR system, or at least the procurement, and that took almost a year with all the planning and discussions and everything. But after that year in the first phase, we had to pivot because we saw that the commercial solutions were either too expensive, had no sustainability, just the support wasn't there. So we also are pivoted towards an open source system. And I think that's one of the critical elements just on the sustainability aspect. Specifically on the death certificate part, we had to have support from different teams because we build it through a commercial company, a local commercial company, so they can provide technical support. However, for us, it was very important as a team that we have access on the code and that we can give support ourselves. So besides the ICE team, also the eGov team is trained for support and just some technical issues to solve them as soon as possible, if needed.
Muchísimas gracias.
Thank you.
De hecho, yo estuve un poco involucrado en la época cuando Bahamas pasó esto.
I was involved when,
Una de
to a
las,
certain extent, when Bahamas went through that process. And one
una de las cosas que nosotros decimos es,
one of the things that we
está perfecto tener un plan,
remarked
sí,
on
está
is
bien
that
tener
it's
un plan,
great to have
pero
a
también es
plan,
bueno saber
but
adaptarse y
it's
el ejemplo
very good to
del
be
lenguaje
able
que usamos,
to
cambiar la rueda del
adapt
vehículo en
along the
movimiento.
way
Y creo que
in
esto
case of
que nos cuenta
unexpected
Michael y Richard son
circumstances.
ejemplos
And
de esto.
as Michael and Richard
Doctora
already
Jacqueline,
said, I think they're very good examples of
lo veo
this
con una
need
pregunta que nos
to
llega.
adapt
¿Nos puede
to
contar,
unexpected or
en
unforeseen
su opinión,
circumstances. Dr. Jacqueline
cuáles son los
Velasco,
beneficios,
what are some
los
of
más
the
importantes beneficios para los
benefits, the
pacientes? Desde
most
el punto de vista de
important
un paciente,
benefits for patients from their
cómo ve
perspective?
que cambia la vida?
How does it change their lives?
Pues hay beneficios a todo
Well,
nivel,
there are benefits at
tanto a
every
nivel
level,
económico,
at
porque
the
ellos no tienen que
economic
gastar
level,
para
because
desplazarse
they
a
don't
un
need to spend
hospital.
as much money to, for
También
example,
el ir
check into a
acompañados de algún
hospital,
familiar, a algunos
and
se les dificulta mucho, sobre todo a
for
los adultos mayores,
family members
porque
that
la familia
accompany
trabaja o
them,
algunas otras
it's
situaciones.
difficult to make
Entonces,
that trip
pues
or
aquí en
visit
la
to
teleconsulta era más
clinics,
fácil que ellos
uh,
acudieran
and they'd have to
sin
take off a day
necesidad
from
de venir
work.
incluso
In this case,
acompañados.
with the
Entonces,
telehealth
esa era
visits, they
otro
can just
beneficio.
check in with a
Aparte del apego al
doctor without
tratamiento, el
having
manejo,
to move
es un
long
manejo muy integral
distances.
el que se da.
So it's really a
Vemos al paciente de
comprehensive
cabeza a
set
pies
of
y vamos
services.
dando
We
seguimiento a cada
check
actividad que
the
vamos
patient
realizando
from
con
head to
ellos.
toe,
Entonces,
and
como les decía
it's
anteriormente, se
pretty
los motiva mucho
comprehensive.
el ver
These are
resultados
things that
y
have
pues
encouraged
aumenta
the patients
su
because they
apego
see
al
results, and this
tratamiento y a sus
also
visitas con
increases
nosotros. La
the
confianza
likely
también, la
follow-up
relación que se
with
pudo
follow-up
hacer con
visits
el
and
médico especialista,
consultations.
también eso fue
And
muy
it's
bueno.
also
Al
another
principio, pues era
benefit
muy
was that
raro ver al especialista así
seeing
de manera
specialists,
virtual, de
at
manera
first it was a little
digital,
strange for
pero
patients to
poco
have
a
that
poco se fueron
virtual
adaptando los
contact, but
pacientes
gradually
hasta que,
patients
bueno,
got used to it
tuvieron la confianza como
until
si él
they
estuviera
felt
presente aquí.
the confidence that it was
Una
almost
pregunta de
for them that
seguimiento
as
que,
if they were
me,
in a
me interesa mucho.
in-person medical checkup
¿Usted notó
experience.
algún nivel de dificultad de los
Did you
pacientes que ustedes
see
escogieron?
any level of
¿Tuvieron,
difficulties with regards to
sé que es difícil
patients?
porque
I know it's
no estuvo
difficult
con ellos cuando ellos trataban, pero
because you weren't
¿se
there
notó
when
algo de
they were
dificultad en
the
el uso de
checkups.
herramientas
But
digitales
did you see
no sé,
any
ellos
difficulties
no
that
sabían
these
cómo
patients
usar la
had in
herramienta, cómo
knowing how to
escribir o algo así?
use
Sí,
the
precisamente con los
computers?
adultos
In other
mayores.
words, digital
De
literacy
repente,
issue.
pues me volteaban a
Yes,
ver a mí, ¿no?
especially with
Directamente y me
the
decían, pues aquí
older
está el
patients.
especialista, aquí,
And
aquí
they
está
had
en la
trouble
pantalla el
sometimes at first
especialista. Y si tiene
connecting
alguna
on
duda, pues hay
screen
que
with the
externar todo
physicians.
lo
And
que
if there
venga
were
a la
any
mente en ese
questions,
momento.
please
Y
ask
si
them,
eso,
whatever
pues hay que
comes to mind.
cambiarlo, pues
So
costó
it,
una,
it,
dos
it took a
sesiones
while
y
to
pues
help
ya
the
después sin
patients
problema,
adapt
pues
and
pudieron subsanar.
transition to these visits, but they
Perfecto.
were able to
Yo
do
creo
it.
que nos va a quedar tiempo para unas dos
Well,
preguntas
I
más.
think
Le
we
voy
have time for a
tratar de
couple more
escoger.
questions.
Ah, esta, de hecho, la comparto mucho.
And this is
Tanto,
something that I
esta es
shared.
para Bahamas y para
This is
Surinam.
for Bahamas and
Eh,
Suriname.
Ustedes hicieron un cambio
You went through a change
soluciones propietarias a código
in,
abierto.
for example, open
Y esto,
source
en ambos casos, el
proprietary
argumento fue
data. And in this
costos y
case, we
sostenibilidad.
know that cost and
Sin
sustainability were
embargo,
issues, but
cuando uno opta por esto, tiene que
when you
pensar en desarrollar la capacidad
use
interna, porque
or when
lo
you
que no hace
opt this, you have
esa
to use
privada,
internal
lo tienen
capacity
que
as
hacer
well.
uno.
Those things that are not
Entonces,
provided by
¿me puede
the
contar un poco?
private sector
Si quieres, Michael, que regreses la
provider.
cámara primero y
Michael,
comienzas tú.
maybe you could, since I see you turn on
¿Cuál ha sido el
your camera
desafío? ¿Qué
first,
están
what are some of the
planificando en términos de
challenges?
recursos
What
humanos?
are
¿Cómo
you
se van a
planning in terms of
preparar
human
para
resources?
darle
How do you
mantenimiento y
prepare
seguimiento
human
a estas
resources to
soluciones?
maintain that follow-up and
Well,
maintenance?
probably to answer that question, I should best begin at the beginning. And when I was onboarded at the same time as our Information Systems for Health ICT specialist. The first thing we did was to draft the TORs for the other 18 persons who are currently a part of the IS4H team. So we have a very small software development team, 3 persons in all, including the ICT specialist. And as I said before, we had developed our own appointment scheduling application. So why did we onboard these persons? We onboarded a small development team. We have 4 trainers. We have business analysts. We have a communication/technical writer. We have persons who we call them implementation specialists. So they do both tech support, help desk type operations. So we had envisioned that we would want to have some amount of continuity. So we would not want to just procure solutions, because once the vendors go away, then the support goes away unless you have the support agreements, which tend to be fairly expensive. So from the get-go, we wanted to have people immersed in the solution who are Bahamians living in the Bahamas that the ministry could onboard if it so chose to do. So we took that approach from day one.
Perfecto. Richard, ¿cómo vieron el tema
Thank you,
de
Richard.
fortalecer recursos humanos?
How did you
Yes.
see this in terms of strengthening human resources and maintenance?
So for us, it was very important to look at the open source solution techniques behind it, because we have, as other countries have as well, resource issues, especially on the technical side. So there is an eGov team available doing all types of digital transformations on different sectors. So what we looked for was a system that had the same programming language and techniques that they were familiar with. And that's the road we took. And on the other hand, what we also said is we had to establish a medical IT department within the Ministry of Health. So we're now setting that up. And we're collecting personnel to support all the digital transformations that we're doing within the ICE4H program, basically. So the support right now is from the eGov team itself and the ICE4H team. And in the near future, it will be a medical IT department within the Ministry of Health and the eGov team together.
Muchas gracias. Y sí, veo muchos países que se fortalece el área de gobierno digital y esto puede
I know
dar
that many countries
cierta
now have been
forma,
reinforcing
facilitar el proceso
the
de adopción
digital and IT
del gobierno,
services, and I
pero
think this
me
would
parece que es
support
importante
open
resaltar la
source.
necesidad
But I
de
think it's also key
documentar bien
to
los costos
highlight the need to
y
document the
tener una buena
costs
idea de
involved and have a
qué
pretty
representa el
clear
adaptarse y el generar la
idea
capacidad
what the
instalada para
costs
poder
are in
implementar
developing
y
this
actualizar
installed
adecuadamente un
capacity to be
sistema
able to
de código
adequately
abierto, para tener
use
eventualmente una
open
buena
source
comparación
so that we can conduct
este enfoque
a
con los costos
clear
de licencias.
comparison, an accurate comparison of what
Con esta
both
última respuesta vamos a dar
processes
finalizada la
involve.
sesión de
So with
preguntas y
that, we
respuestas
have now
y
finished our
quería
Q&A session,
agradecer
and I'd like
mucho
to
al tiempo
thank
que dedicaron nuestros
you
colegas
for
de
devoting
México,
this
Surinam y las
time
Bahamas.
in the
Agradezco las
Bahamas
palabras
and
de nuestro
Suriname,
nuevo jefe de
Mexico,
división y
and
de
I'd
Marcelo
like
Agostino de la
to
Organización
offer the
Panamericana de la Salud
floor to Marcelo
y
Agustino
también a
from the
todos los
Pan American
participantes que se sumaron. Espero que
organization.
haya
And
sido
I'd like to
provechoso
thank
para mí
all of
saber
the
de doctor Sosa.
participants who
Y antes de
were
cerrar, solo
involved.
quería pedir
Before
si
I
pueden responder una
conclude,
breve encuesta sobre el
I would also
webinar.
like to
La
ask
pueden
if you
hacer a
could
través del
please
código
fill
QR
in
que figura
this
en pantalla
survey.
en el
Just
chat.
click onto the QR
Si nos
code,
ayudan
and
a
if you
responder
could
estas
help us
preguntas,
out in
nos van a
answering
ayudar a
the
mejorar
questions in
y
the
pensar un
survey
poco en cuáles van a
in an
ser
effort to
qué temas
improve
abordar y cómo
our
abordar los
future
temas que más sean de
dialogues,
utilidad
and what else needs to
para
be
ustedes,
included
los
among some of the
de
subject
WordPress.
matter that would be of interest
Y
to our
muy pronto estaremos
participants.
publicando un blog sobre este
Very soon,
webinar y
we're going
subiendo a
to
YouTube la grabación en
uploading
tres
on
idiomas.
YouTube the
Así que
presentation in all three
nos vamos a
official
ver
languages.
en YouTube.
And so you
Muchísimas
can see
gracias a
that on
todos.
YouTube. And I'd like to
Les
thank
deseo una
everyone
excelente semana.
and have an excellent week.
Gracias, igualmente.
Thank you. You too.
Thanks, everybody.